can you combine ADCs with targeted therapies, like with osimertinib, for example?
So that's a question that's being asked. Yeah. Yes, so osimertinib plus Dato-DXd is an example, right? That is something that is currently being evaluated to figure out, one, is it tolerable? And second, can we get an efficacious response that's meaningful to patients? I'm excited about it, right? If you think about the mechanism of action, you very nicely described ADCs. EGFR-driven disease tends to remain EGFR-driven, and so do you keep that backbone, right? We've asked that question. There was a recent COMPEL study that came out at the World Conference of Lung Cancer. And essentially, it was prospectively asking the question, if a patient experiences disease progression on oral targeted therapy, osimertinib, at second line, do you keep that OC backbone going, but add in platinum chemo, or do you drop it and just stay with chemo? This was a practice reinforcing study, in my opinion. It showed us TLDR, right? That yes, it's meaningful. Yes, you're going to see CNS disease protection if you keep the OC backbone going. And so logically, it makes sense to me that these combination strategies will be the answer.
No, it makes perfect sense. We do the same in breast, when we target the estrogen receptor pathway. We tend to keep on going, even though patients are progressing on multiple lines, but we keep targeting that plus adding other stuff to it.
Right.
So it makes perfect sense to keep doing it, because I truly feel cancers are very heterogeneous.
Yes, absolutely.
Right? They have multiple clones.
Absolutely.
So sometimes a clone emerges maybe that's not responding to osimertinib, but there is the other clone that's responding to it is still there.
Right.
But you've been put in under check by that drug. Now, if you're going to stop the drug and go to something else, it's not under check and it can start growing again.
Absolutely.
So it makes so much sense doing both.
Let me ask you a question. So in lung cancer at time of progression, if a patient is on EGFR-directed therapy and then we start to see disease progression, if we can get a biopsy, I'm pushing for it because I want to repeat tissue profiling. I want to understand the reason for acquired mechanism of resistance. Can I target it? Can I not? Do you guys do that in breast cancer?
Yeah.
Okay.
No,
Teach me.
This is very important for us. So at every progression, what we recommend at a minimum, a liquid biopsy.
Yeah.
So you can check for emergent mutation of resistance that you can target. But if you can get a tissue biopsy, it's always the holy grail.
Absolutely.
Right? Because then you can do all the immunohistochemistry stains that you cannot do at this point in time via liquid biopsy. So you cannot get insight on the receptor status for us, for example, by doing a liquid biopsy. Is liquid biopsy something you guys are doing, or you also like more tissue?
Yeah, I mean, so tissue is our gold standard, but you're right. Liquid biopsies at any time of progression, I'm often ordering that, but you can't always trust it, right? It depends on tumor shedding levels. You can't get IHC testing, and importantly, with a liquid biopsy, you can't check for histology transformation. So small cell transformation can happen in up to 10% of cases. If patients have EGFR-directed disease, EGFR mutated disease, they have non-small cell lung cancer, you need to be looking for histology transformation. So.
This is amazing because also it's 10 to 15% of hormone positive that can turn into triple negative.
Okay, so we have a lot more commonalities than I thought. I didn't realize.
We do. It's fascinating, right?
Yeah.
So that's another thing why you want to check the receptor status, because you want to see if they convert it to triple negative, which is fascinating.
Wow, okay. See, I'm learning so much from you.
Yeah, me too. 10 to 15%, which is fascinating.